right, I'm gonna go ahead and read you a little bit of information about Dr. Kalyn Holmes. She's recently completed her doctoral degree through the University of Hawaii's clinical psychology program. She's currently a psychology resident and soon to be the policy and advocacy postdoctoral fellow with Denver Health Hospital Authority in Denver, Colorado. An excellent hospital, if I say so myself. Kalyn's research and clinical interests are primarily centered around improving and increasing access to emotional and behavioral health care for underserved and underrepresented populations. On a personal note, Kalyn has been freezing in the Rocky Mountains this past year and is deeply missing the Hawaiian Islands. So at this point, we will turn it over to you, Dr. Holmes, for your presentation.
Thank you so much. Yeah, like the intro said, I've been really missing Hawaii, so it's great to have some kind of contact, even if I can't be there in person right now, sharing some of my research with CAMHD. So give me just a second to share screen. I mentioned to Tristan, I feel like every time I do this, I have to refigure it out. So. All right, can you guys see the first slide now? And only the first slide, not my notes to myself?
Yes.
Perfect. All right, I'll go ahead and jump in. Yeah, Kalyn Holmes is my name. I use she, her pronouns. So if anybody needs to address me directly, that's how you can do it. And I will be presenting today on my research that I did while I was in graduate school. This is my last week before graduation, so hooray for that. And I'll be presenting on treatment-focused diffusion as an indicator of immediate and long-term outcomes in youth public mental health care. Okay, so just to set the agenda, first we will go over some background, kind of orient everybody to this area of research. And then I'm going to talk about the shared methodology of the 4 studies I did rather than get into the nitty-gritty of each one. But if people are interested in that, I will have my personal email at the end and you can email me. We can chat about stats sometime if you really want. I'm not good at it, but I can try. And then we'll get into the findings for studies 1 through 4, talk about some big picture takeaways and potential implications, where I'm going with this research. And then I have some just food for thought, some things that I've been thinking about with this research that I'd love to share with other people. So I promise there's not transitions for each slide, just the first few. All right, so background. We'll start with treatment planning. So as a lot of us know, determining what concerns should be targeted in treatment is one of the first and most important steps for therapists and clients undertaking psychotherapy. And I think one of the most common approaches to treatment planning, or how a lot of the evidence base would suggest, is to address the principal psychiatric diagnosis, or the big diagnosis is the reason for referral. And in line with that, most of the evidence-based treatment protocols maintain a narrow treatment focus by targeting on just one problem or psychiatric disorder. So if you're thinking like TF-CBT is only focusing really on trauma, Coping Cat, right, is really only focusing mostly on depression, that type of thing. But we know, right, as mental health providers, clients often present with more than just one diagnosis, which can complicate treatment planning whenever most of the manuals out there are just for one diagnosis. Fortunately, there are a number of evidence-based treatment protocols for comorbid psychiatric diagnoses. Many of these are based on transdiagnostic approaches, which really focus on targeting underlying factors that are shared by multiple co-occurring diagnoses. And then there are also treatments for multiple concerns that are more like modular cognitive behavioral therapy that balance flexibility and fidelity by allowing for therapists to kind of take a second and address barriers or address impairing secondary concerns before coming back to the primary diagnosis or the primary concern. So big picture, both transdiagnostic and modular therapy approaches still kind of maintain a relatively narrow treatment focus by doing those different things and bringing things back to the primary concern. And narrowly focused treatment protocols like those and the ones that are just for individual psychiatric diagnoses have gained a lot of evidentiary support in randomized controlled trials, suggesting that maintaining focus on one or a few concerns is an important aspect of effective treatment. So the idea of maintaining a narrow treatment focus is all well and good, but how easy is it to do in reality, right? To illustrate what many of us as therapists face when we're trying to treatment plan, I thought it would be helpful to just go through a little example here. So let's say we've got an adolescent with a principal diagnosis of depression, but they've also been acting out and now carrying additional conduct disorder related to things like running away, threatening others, engaging risk behaviors, so on and so forth. And then on top of that, so on top of these diagnoses that we might have some suggestions on how to treat from manuals, they're also struggling with non-diagnostic concerns like getting to appointments because of transportation issues, maybe low family support, not getting a lot of encouragement at home about attending treatment, and then feeling unengaged maybe due to stigma around mental health therapy and mental health supports. Now, that seems like a lot at once, right? But those of us who work with teens, and those of us especially who work with teens who are coming from like underserved populations know that this is a pretty typical case presentation and that cases can get even more complex than this. And therapists who are treating clients with these co-occurring problems that don't have a clear shared underlying factor are in the difficult position of choosing which concerns to address and which to ignore. And, maintaining narrow treatment focus in these situations can be really tough. I know I myself as a therapist, I found it really difficult to stick to just one or a few things whenever a kid walks into my office with several complex overlapping concerns, which has led me to studying this thing I'm calling treatment focus diffusion. So this is a fairly new area of study, and I'll just take a second to clarify what exactly I mean by treatment focus diffusion. So this term refers to the spreading of treatment focus across multiple co-occurring problems, both diagnostic and non-diagnostic, during the course of a mental health treatment episode. And there is emerging evidence that treatment focus and treatment focus diffusion is an important but understudied factor in psychotherapy. Specifically, some previous treatment research studies have found that the spreading of treatment focus across multiple diagnoses is related to smaller and often non-significant effect sizes, as we can see in this figure that summarizes the findings of Hawai et al. 2017, who looked at the effectiveness post-treatment and follow-up for different manualized treatments, including multi-problem protocols, which if we look there, much lower than the rest, especially at follow-up. However, this research was limited to examinations of evidence-based treatment protocols and psychiatric diagnoses, giving us a clue that treatment-focused diffusion might be related to worse clinical outcomes, but leaving quite a few questions, including what about treatment-focused diffusion that occurs in non-manualized treatments? Or what about when treatment focus isn't just limited to diagnosis, like that client I mentioned in the example? These questions are especially important to consider in publicly funded mental health care, or public mental health care. PMHC is probably what I'll end up referring to it as I keep going. But PMHCs, like Hawaii's CAMHD, might be particularly susceptible, and there's a few reasons that we suspect that that might be the case. Firstly, the clients who are seen in PMHC, these systems tend to serve youth and families with more comorbid diagnoses, higher levels of impairment, more non-diagnostic concerns like life stressors and sudden crises, and less resources for accessing other sources of mental health care. All of that combined together can make treatment planning really difficult and more complicated. And on top of that, providers in public mental health care, so the folks who are serving these multi-need complex clients, are providers who typically have high caseloads. We're often juggling a lot. And then also don't always have the same resources that maybe somebody in different settings might, specifically resources around ongoing training, maybe consultation groups, clinical supervision, that type of thing. And then because we're all stretched out and have all of these complex cases, public mental health care therapists often experience high turnover, frequent burnout, and compassion fatigue, which I'm sure I'm preaching to the choir. We've all been there, especially coming through COVID. All right, so often in public mental health care, just to summarize where we're at now, you have this combination of complex, high-need cases and stressed out clinicians who are trying to keep up with large caseloads. Therapists in this situation are likely to engage in treatment-focused diffusion. I know I have, whether that's intentionally or unintentionally. In fact, public mental health care therapists have been found in our previous CAMHD research to target many and diverse treatment foci and to attempt a wide variety of therapeutic practices in order to address those concerns. So these treatment choices in previous research have been found to be made thoughtfully and appear to be based on individual case specifics, but they make public mental health care treatment look really different from what we see in like the treatment literature or evidence base. As such, findings from the current psychotherapy literature cannot always be assumed to be to universally apply to our public mental health care populations. Which brings me back to treatment-focused diffusion, because we did see right in that Weiss et al. That in RCTs or randomized control trials and where multiple psychiatric diagnoses are concerned, manuals designed for multiple problems show smaller effect sizes. But until now, this hadn't been researched in public mental health care systems who might have even more co-occurring problems than what's seen in these randomized control trials with really strict exclusion and inclusion criteria. All right, so the aims of this line of research are threefold. Firstly, I aim to examine the extent of treatment-focused diffusion in service formats commonly seen in public mental health care systems, and then also understand if and how treatment-focused diffusion is related to clinical and system outcomes. And then finally, I wanted to explore if there are possible differences in that treatment-focused diffusion and outcomes relationship between different service formats often seen in public mental health care continuum of care. Okay, so now we'll get into the shared methodology. All right, firstly, I think it's really helpful to kind of contextualize the research and the data. So my data was collected by and then gifted to me from the state of Hawaii's Child and Adolescent Mental Health Division, CAMHD as most of us know it, specifically between July 2006 and June 2019. And then the service formats that were included in this series of studies were standards-based intensive in-home, so our IIH service format, which is our most common one. You'll see that when I get to the kind of breakdown of participants. IIH is our biggest one in CAMHD, and it is most like what the treatment literature often refers to as treatment. We also included multisystemic therapy, or MST, which is an evidence-supported treatment package where therapists are available 24/7 to clients, and there is, as part of their package, mandated regularly scheduled supervision. So kind of similar to MST, also looked at functional family therapy, or FFT, which is, again, an evidence-supported treatment package, but looks a little more similar to typical outpatient whenever compared to MST. So where MST folks are available 24/7, with FFT, it's more like you might see your therapist 1, 2, 3 times a week, so less of that immediate accessibility. But they also, similar to MST, have mandated regularly scheduled supervision. And then finally, we also looked at an out-of-home placement for therapy, community-based residential care, which is a home-like residential environment setting where kiddos have access to mental health staff 24/7. And CBR also typically sees higher severity client presentation, so maybe more functional impairment, more comorbid diagnosis, kind of. All right, and then this is the breakdown of my participants. So this is specifically from studies 3 and 4, because that was the most recent data. But as you'll see, SBIIH, quite a bit larger than the others. And then FFT was the smallest. So kind of across them, you'll see there are a lot of similarities. Disruptive behavior disorders comes out as our most common primary diagnosis, which is consistent with other CAMHD research. Similarly, the racial identity is multiracial is the most common one. And then you'll see a lot of the breakdowns are similar, but CBR tends to have the more intense cases, FFT slightly less. And then interestingly, I haven't made anything of it, but FFT is the only one where people identifying as male are not the majority. Okay. And then briefly, I'll go over measures. So we use the CAFAS, or Child and Adolescent Functional Assessment Scale, for folks who might not be familiar. It's a measure of youth functioning across several domains, and it's regularly completed by care coordinators in the CAMHD system. Higher scores on the CAFES indicate higher levels of impairment. I use this to account for initial functional impairment in a lot of my analyses, and then in some of them I also used it to look at differences from the initial CAFES to the final CAFES. And then I also use the monthly treatment progress summary, MTPS for short. It's a monthly therapist report measure completed by all therapists in CAMHD. Specifically in that time date, we have moved away from it from now, but in the past, this is what we use in case anybody's new and doesn't know. But it's a measure of both treatment targets. So as you can see here, this is the predetermined list of treatment targets that therapists can indicate what they focused on in the month. And then they also rate the progress on each treatment target for the month in a scale of 0 to 6, 0 deteriorating, 6, 100% improvement. And so that's what I mostly looked at, is the treatment targets and progress ratings from the MTPS. The primary predictor variable was, of course, treatment-focused diffusion, but specifically in the first 5 months of treatment. Wanted to be able to kind of capture that time frame to get a little bit of an early indicator. And we operationalize that as the number of unique treatment targets per month. And then for outcomes, we looked at immediate outcomes. So we looked at those progress ratings that I mentioned before, both the rate of change and the 5th month progress rating. And then we also looked at functional improvement, like I mentioned, that comparing the final CAFES and initial CAFES. Then we also looked at some nice long-term outcomes. So we looked at whether or not somebody returns to CAMHD after being discharged from their first treatment episode. And then we also looked at treatment expenditure associated with any subsequent services. So for those who came back to the system, how much cost they accrued from different services. Okay, so now we can jump into those findings. The fun stuff. All right, so in study 1, I found that overall treatment-focused diffusion was lower in MST, and that was even when accounting for other factors associated with case complexity, like functional impairment levels and number of diagnoses. I also saw that treatment-focused diffusion predicted slower progress or less change across the first 5 months of treatment, as well as lower progress ratings in the 5th month. And then if you look at that yellowish, orange, solid and dotted line in the figure, you'll see that this was especially true for MST. So you can see that the difference between low and high MST treatment-focused diffusion is a lot more prominent than the SBIIH. Okay, and then in study 2, once again, looking at IIH and MST, we looked at treatment-focused diffusion's relationship to functional improvement, so changes in the CAFES from time 1 to time 2, or initial to final. And here we found that once again, higher treatment-focused diffusion did predict worse outcomes, so less improvement over the course of therapy, and that this was once again particularly true for those in the MST service format. Okay, and then in study 3, once again, IIH and MST, but this time looking at those longer term outcomes. So here we found once again that higher treatment-focused diffusion predicted a higher likelihood of somebody returning to services after their initial discharge from CAMHD. And then also we found that those with higher treatment-focused diffusion accrued more cost over time. And that this was more true slightly in MST, but as you can see with the longer term outcomes, there was a little bit more similarity between SBIIH and MST. Okay, and then in study 4, I finally got off of the IIH MST train and started looking at CBR and FFT. Firstly, in CBR, we found that treatment-focused diffusion was a little bit higher than in SBIIH or in MST, with a average treatment-focused diffusion of 2.64. So that's 2.64 unique treatment targets each month, different treatment targets in the first 5 months. Okay, and then where the relationship to outcomes is in regards to, I guess, the outcomes, higher treatment focused diffusion was related to worse progress, both slower progress over the 5 months and lower progress ratings at the 5th month. It also was significantly related to less functional improvement over the course of therapy. And then in FFT, you'll see lower levels of treatment focused diffusion actually. And then where their relationship between treatment focused diffusion and outcomes is that higher treatment focused diffusion was related to a higher likelihood of returning for additional services after being discharged from your initial treatment. Okay, so we talked about each of the individual ones. I find it very helpful to smush all of these together and take a bird's eye view. So let's take that bird's eye view together. So as you can see here, there were some differences across the 4 service formats in the average number of unique treatment targets endorsed across the first 5 months of treatment. So those numbers, instead of just being each individual month average, those are calculated for the full 5 months. So in the first 5 months of treatment, CBR therapists endorsed approximately on average 13 different treatment targets. And then on down. So CBR obviously had the highest by quite a bit, FFT the lowest. And then one thing that I really want to point out here is that both MST and FFT were on the bottom end of the treatment focused diffusion spectrum. I'll get into a little bit more of why that might be, but interestingly for MST, this was despite having similar levels or higher levels in some cases of comorbid diagnoses and functional impairment. All right, and then in this figure, you can see this is the standardized effect sizes for each study of the relationship between treatment-focused diffusion and a given outcome. And so relationships between high treatment-focused diffusion and worse outcomes are on the right of that solid line. And then the opposite is on the left. As you can see, almost all of our findings were in the expected direction, with higher treatment-focused diffusion predicting worse outcomes, with the exception of treatment-focused diffusion's relationship to progress ratings in FFT. So this was interesting because this was a truly mixed finding. While higher treatment-focused diffusion did predict better 5th month progress rating, which is the opposite of what we expect, it predicted slower progress. So some good, some bad, but did not turn out how we expected. Okay, and now we can get into the more kind of fun discussion-y type stuff. So the big picture takeaways, implemented evidence-based services who have more access to ongoing clinical training, program structure, resources, and supervision consultation. FFT and MST appear to maintain relatively narrower treatment-focused diffusion levels. And treatment-focused diffusion is generally associated with poorer outcomes across various measures and in different service formats. And then finally, treatment-focused diffusion levels and treatment-focused diffusion outcome relationships appear to look a little different in different service formats, specifically with MST having the most consistent and strongest relationship between treatment-focused diffusion outcomes, and CBR being a close second, with it consistently predicting initial outcomes in CBR. So some clinical implications, treatment-focused diffusion, I think, might be a useful early indicator of how treatment is going, and would be useful for monitoring and kind of as a clinical decision-making tool. So you could see a situation where a case is flagged if treatment-focused diffusion is getting high in the first couple of months. Maybe there's a team meeting to talk about, like, does this kiddo need more intensive services, higher level of care? Does the therapist need a little bit more support in trying to figure out how exactly we can meet all of the needs of this family, that kind of thing. Also, I think providing access to regular supervision for community and public mental health care therapists, the kind of supervision and consultation access that we see in MST and FFT, and lots of similar, different kinds of evidence-based packages. Access to those kinds of things, I think, might really help maintain narrower focus. So, and then finally, it could be that some treatment-focused diffusion reflects deviating away from an established treatment plan in order to address barriers or address like those non-diagnostic concerns that we kind of mentioned with that initial example, that sort of thing. And so being able to identify possible barriers early in treatment could benefit clients and clinicians. So my future directions, I want to keep exploring exactly what treatment-focused diffusion is, what contributes to it. Like I said, this is a fairly new area of study. Not a lot of focus has been given to treatment-focused or treatment-focused diffusion in the past. And so we're still kind of figuring out, what is this? What does this look like? Are there differences between like intentionally or unintentionally diffusing treatment focus in therapy? Sort of the thing. I also would love to, at some point, hopefully soon, get into like doing qualitative interviews and things like that with clients and clinicians in order to kind of get their perspective and input on what gets in the way of executing treatment plans, what gets like what I guess adds to treatment and what gets us off track, if that is part of what's happening with treatment focused diffusion. I think this would especially be helpful at like kind of the local level in order to see if there are differences, like things that get in the way in Colorado might be very different from things that get in the way in Hawaii. I'm sure there are some commonalities, but you know, we all have those same things that kind of come up, but still. Oh, that one came out all janky, but I think eventually too, trying to get some controlled trials going would be nice so that I can actually maybe make statements about causal relationships in the future between treatment-focused diffusion and outcomes. All right, and then as promised, just some food for thought. Like I said, there is still a lot of research to be done in this area before we can say what exactly is going on here with the treatment-focused diffusion phenomenon. However, I have some thoughts about things that I think would be helpful for reducing treatment-focused diffusion. Obviously, take what feels right to you in your organization and your personal practice and leave what doesn't. These are just some opinions I have after doing this research. So, but let's start with what can we as therapists, providers, mental health practitioners do to try to reduce how much we are diffusing focus. So firstly, I think early and ongoing thorough assessment aimed at identifying targets that might contribute to multiple presenting problems. So taking that kind of transdiagnostic approach of like, what's really the driving mechanism under a lot of these problems can help us target those and keep coming back to them in treatment. Kind of in the same vein, I think utilizing a collaborative treatment planning approach with youth and families that includes identifying and planning for potential barriers could help alleviate some of that treatment-focused diffusion if we kind of know ahead of time. Transportation might be an issue for this family, or this family has a hard time maybe making ends meet, and so it might not always be possible to contact them via phone, those sort of things. And then using supervision, fidelity measures, peer consultation groups whenever possible. I realize that's not always, I think, a privilege that every one of us has, but whenever they're available to us, I think trying to lean on peers, I know I do often, can really help us see things that we're not seeing in a case. And then use of practices and processes that are designed to address underlying factors or that are really applicable to multiple concerns. So I know I've said transdiagnostic probably 1,000 times, but something like transdiagnostic manuals, and then something that we referred to in the Child Center for Cognitive Behavioral Therapy at UH often as hip pocket practice elements. So those practice elements that can apply to several different things, right? Kind of no matter what crisis of the week somebody comes in with, you can do some problem solving, some grounding, some cognitive restructuring, and try and bring things back to those underlying skills that would help. And then what can systems do to help with treatment-focused diffusion? I'm very into systems research, so I apologize in advance if I get on a bit of a soapbox, but I think it would be helpful if systems can find ways to provide time, space, and resources for clinicians to access those things I was talking about, like ongoing trainings, regularly scheduled supervision, and consultation groups. Because, like I said, might not always be something that all of us have the privilege to access. And so if systems could support clinicians and providers in that way, I think it would be great. And then also integrating other and related professions into systems so that we're all working as a multidisciplinary team for families. For a lot of systems, I think that's there, but not always clear how to access it. So both of those, but so yeah, so some of the professions that I think would be helpful, obviously, social work, deeply needed, psychiatry, legal aid, addiction recovery, medical care, just to name a few. Because I think, you know, we often end up wearing multiple hats as mental health providers in public mental health care settings. And some of those hats maybe we're not always the best equipped to be wearing. And so if we could get our clients to the experts in those areas and we can focus on emotional and behavioral treatment, I think that would help reduce treatment-focused diffusion and make our lives easier and make our clients' lives better. Okay, and then finally, I think it'd be helpful if we can consider systems potentially implementing services that are designed to address the concerns of multi-need youth and families, such as wraparound services, modular approaches to treatment, and then family and systems treatment packages like MST and FFT, like what we have in CAMHD. Okay, and I know sometimes it's hard to hear like what we think systems can do because you're like, I'm an individual, I am not a system, I have no power. But we do have some power as individuals to advocate for system change in different ways. So just some thoughts I have on like how we can try and advocate for those changes, including following current mental health or legislative bills, mental health legislative bills at the federal and local level. I have a link there. I don't know, hopefully I can send out my slides at the end. If not, take a quick picture. You can also write, call, or email your local reps and senators. There's a link there also if you are unsure how to figure it out. I had to Google that one myself. And then using your platforms to raise awareness, talking about mental health bills, mental health measures, raising awareness on social media, in the office, those kind of places. And then always sign waving and volunteering. I definitely miss going out and sign waving for KQ Mental Health Awareness Month in May. So if that's something you're interested in, you can also Google that. All right, thank you all. I want to say a big thank you to CAMHD. Love you, CAMHD, so much, miss them deeply. And thank you to the youth and families of Hawaii, and of course to the providers who serve them. You know, you're doing such good work, and I think it can be often gone unthanked, but I want you to know, super appreciated. And there is my personal email too. Like I said, if anybody has questions or thoughts that doesn't get addressed now in kind of the discussant period, feel free to shoot me an email. Those are my references in case anybody likes them.
Okay, great. So thank you so much, Kalyn, for that excellent presentation. It looks like we have time for questions before we go to the panelist discussion. So if you have questions, feel free to type them in the chat, I think, and there might also be a way for you to use the Q&A as well, if you want to type your question in there. Tristan, I'm not sure. I think it might be my job to monitor for questions and then read them aloud. And I'm not seeing many, I don't think. I'm seeing a lot of very positive feedback for that excellent presentation, which is very warranted. Okay, well, I am going to introduce our panelists for the discussion. First, we have Dr. Kimberly McDonald, who obtained her Doctorate of Psychology degree from the Forrest Institute of Professional Psychology in Springfield, Missouri, in August 2002. Prior to that, she completed her clinical internship at the Youth Opportunity Center in Muncie, Indiana. And having enough of the Midwest, she moved to Hawaii for her postdoctoral training with Kapiolani Child Protection Center that same year. Loving Hawaii, she found a clinical psychologist job after her postdoc with the Hawaii Department of Education in October 2003 in the Central District. She recently transferred from Central District LMW to the State School-Based Behavioral Health Program Office as the State Clinical Psychologist. Kim has nearly 20 years of experience in DOE, and combined with her previous experiences, she has conducted hundreds of psychological evaluations, mainly with children and adolescents, as well as therapy, counseling services, and clinical supervision of many behavioral health specialists in Hawaii DOE. And our second panelist is Dr. Puanani He, who was born and raised on Kauai. She received her undergraduate degree in psychology with a minor in anthropology from Oregon State University and her Ph.D. from the University of Hawaii at Manoa Clinical Studies Program. She began working as a clinical psychologist for CAMHD's Kauai Family Guidance Center in 2018 before transitioning to her current role as the clinical director for CAMHD's SAMHSA-funded System of Care Grant Data to Wisdom in 2021. She is passionate about system of care improvement and increasing access to quality mental health services for those in underserved communities. Her research focuses on identifying patterns of effective practice in community care settings. So thank you both for agreeing to be panelists, and I will turn it over to you to share your thoughts.
And I'm going to jump in and turn it over to Pua because I think she has a lot more to say about the results from CAMHD before I jump in.
So thank you, Kim. I was gonna volunteer you first, but I'll go ahead. Kalyn, really great study, interesting, obviously in the context of the work that we do at CAMHD. I have questions and thoughts, and I'll try to organize them in a cohesive fashion. But first, I really like that you explored this area of treatment focus diffusion in across levels of care in CAMHD. I think so often much of the research that's done has really been centered on our intensive in-home level of care, which is great, but I think it's also really interesting to see how findings carry across the different service formats we have as well. It was really interesting, I think, to see how we saw some differences in terms of maybe what we could consider to be levels of impairment. Even I think a lot of times we think of intensive in-home as really kind of our lowest level of care, and CBR as one of the higher levels of care, as from the four you described. And it was really interesting to see how what treatment focused diffusion looked like across that spectrum. I am curious if there is like some sort of sweet spot at which point in time we consider ourselves getting into this area of treatment focused diffusion versus more non-diffused treatment focus, and kind of really what some of the practical implications are there. I also think, and you had referenced this earlier on in your presentation, you were using data, it looks like, from the monthly treatment and progress summary, which did collect those targets each month of services. Just a super exciting aside, the DOE, the Department of Education of Hawaii, is also really sharing in these the shared ontology, if you will, with CAMHD. So we are using the shared language of treatment targets and practice elements in our service of youth in Hawaii, which is really exciting because I think it really helps to center us all around shared goals and a common language in our service of youth and families. But not derailing. I am curious though, since we've moved away from that monthly collection of data, I'd love to know more about how that looks in this session by session format that we're collecting data in now, and what that really looks like over time. I know that's not a question we can answer today, but I think it's certainly on the future directions list. I have more thoughts, but let me stop there. So Kalyn, you may, and Kim can also respond, and anybody else to those too.
I agree that I'm very, very interested now that we have moved to the like session by session stuff. Like just to see how that works out, see how like what treatment focused diffusion looks like in those spaces at a session by session, and how again it might differ based on level of care or by impairment. Because yeah, the sweet spot also that you mentioned is something that I will need to keep digging into, but also that I was thinking about, especially you know, FFT had the lowest levels of treatment focused diffusion and had the least consistent or strong relationship between treatment focused diffusion and outcomes. And so one of the things I was kind of thinking that might be related to is that maybe there is a threshold of like treatment focused diffusion below this level maybe is not related to worse outcomes in the same way. And then once it gets to a certain point, maybe that's when it starts to become too diffused.
Yes, absolutely. The other thing I was thinking about is just so CAMHD engages in co-managed care with our contracted service providers. So we share in this big picture of what we would like folks to focus on in treatment services. And prior to the referral, the youth's clinical lead will actually develop and identify certain targets that they'd like the provider to really prioritize in their work with the youth and family. That then gets tailored into a treatment plan, and then ultimately the specific targets used in session are recorded in a progress note. But what your study makes me curious about also is just thinking through what the initial ask is. And this, you know, I think in other systems could even be like, what are initial recommendations that are made from an evaluation or something? You know, how does that have implications down the road then? And in terms of what's prioritized, when it's prioritized, and how that also relates to treatment focused diffusion as well. I don't know if either of you have thoughts on that, but I think that's an area that would be interested to explore in more in the future.
I don't have any specific thoughts on that. I will add in or do a disclaimer that I am not a research person. I am a definitely more a practitioner person in my work. So I will admit that I am not up on statistics or the processes to do research, but I would love to see this replicated in the Department of Education in some way. As Pua mentioned, we are moving towards collecting and setting up a system that collects better data, very similar to what CAMHD has been doing for years. I don't think we have definitely don't have the large sample size that they would have, but we're hopefully in a few years we'll have some more related to the things that are very similar to what you're getting in CAMHD. I just want to throw in there, I don't know how familiar anybody is with managing and adjusting practice or adapting practice, from PracticeWise. That is an initiative that we have taken on in the Department of Ed to help shore up our direct service providers and supervisors in providing evidence-based services. And a big part of that is providing a framework to kind of deal with some of that treatment diffusion. So yes, we identify a primary focus, but we also at the same time identify the things that are potentially going to interfere with that treatment focus. And there is some fluidity in, adjusting the focus if we see, we notice that what's underlying what we thought was the primary focus initially we can adjust that and, address all of those things at the same time as much as we can, while hopefully not losing focus. It's not perfect by any means. We're still new in all of that. But I think it would be interesting to see how that plays in with this as well. And I think DOH is also doing some practice-wise stuff. So
Yeah,
that
I
would
can
be-
speak a little bit to that, and Kurt can jump in too. But excitingly, CAMHD is also providing trainings in managing and adapting practice for providers across many of our levels of care also. And I think that really, like Kim, just like you're saying, it really, I think, supports more of that kind of a transdiagnostic approach to services, and that practices, may be used for multiple targets of treatment, and then also really provides hits on some of the recommendations, Kalyn, that you made around supporting providers in terms of consultation. I think there's also supervisor training that occurs, so I think that really meets many of some of those pieces of the recommendations, and is another exciting parallel initiative across the two big service systems as well. Scott and Kurt, I don't know if you want to say anything about that.
I did want to say something, but not about practice-wise, but you have brought up the transdiagnostic approach, and I've been in many supervisions with MST and FFT, and they never, even when it comes to eligibility in their program, they never bring up diagnosis. It's not in their vocabulary. So Dr. Holmes, while you were talking about things like lower caseloads, which they do manage, both of those programs manage caseloads, that there's mandated supervision, all of that probably contributes to lower levels of diffusion, but also their perspective is not diagnostic. And so it makes me wonder if that is a factor as well.
Yeah, hopefully I didn't cut anybody off just now, but I definitely think so. That's something, I think our field is trying to go more and more towards not focusing on the DSM diagnoses as much as we are focusing on like what are the actual problems that are happening for this kiddo, this family, that are driving some of these issues, right? Because they can't always just be captured with diagnoses, which is why I wanted to include those non-diagnostic. I think that perspective of getting away from I'm treating a diagnosis and more I am treating a whole child or a whole family system definitely can help.
And that's kind of one of the major differences between CAMHD and DOE. We don't require diagnosis before doing counseling or any kind of support services for the student related to what may be interfering with their education. So again, replicating the study or something similar with the DOE data would be very interesting for that reason as well.
And what I'll say on the CAMHD end is that while a diagnosis is required for the purposes of eligibility, we do really practice within a, we use a treatment target approach to clinical practice, and are really mindful of the strengths and challenges that the youth encounter, is experiencing when developing treatment services and a treatment plan also.
Yeah, I was just going to comment that the timing of this presentation to kind of coincide with the CAMHD and DOE efforts to bring the managing and adapting practice kind of modules into the system to a greater degree it's perfect timing, right? Because those things are just going to go a long way to giving clinicians those approaches that they can rely on for a transdiagnostic kind of a way of addressing cases and problems, and they should be able to notice less meandering of their treatment practice into all kinds of other areas. They should be able to, hone in on the more kind of pertinent issues and the underlying things that are impacting all kinds of problems that are popping up for the kids. So to be kind of reminded in this presentation of, what the treatment focused diffusion actually ends up meaning in terms of worse outcomes in a few different, ways, I think just really goes to reinforce the importance of what it is that DOE and CAMHD are doing to kind of help, build up the practices of the therapists out there that are working with our kids to kind of avoid going into those treatment diffuse paths.
There's been some comments, Micah, I think I'm completely excited about it as well, that we're going to have this statewide system that collects the same data, uses the same vocabulary, practices the same practices. So I think that's great. And Dr. Stern also made a comment, and can he talk, or I don't know how that works?
No, unfortunately not.
Okay, sorry.
I also realized that some of the comments we're getting are just directed at the hosts and panelists, and I don't know if everybody's seeing them. So one of the comments that Scott was just referencing was just highlighting that it's great the two systems are really using a shared approach to treatment, so that there was exactly the same access to evidence or research-based practices, and hopefully closing any gaps that might exist between both of the agencies. There's also a comment that we received just that the presence of a medical home is a strong predictor of outcomes, given that it predicts coordination of care, using an interdisciplinary team-based approach. Kurt, I don't know if you have any thoughts that you want to share on that piece related to this.
No, not really. I mean, I think that comment really speaks for itself about, the medical home really being that interdisciplinary team-based approach. That does, I think, bring a lot of improved outcomes to treatment. Yeah.
Yeah, and I know that one of the I don't know if it's a food for thought or a recommendation. I can't remember. It might have been a food for thought, but it's just that some of the approaches that may address some of the underlying factors or barriers for families, even like a strong care coordination or even wraparound approach, might be really beneficial. And what I will say, and I hope Kim would agree, is just working in children's mental health, there are, I think we both see care coordination as a really strong element of serving our population, and that there is also beauty of really working within an interdisciplinary team to serve the youth. That being said, I think the recommendation is that can be done perhaps in a much more coordinated way, especially when we factor in, the bigger topic of treatment focused diffusion.
Yeah, when Kalyn mentioned that sometimes we take on the roles of like social worker and, doing some of that as a therapist, it definitely, they can contribute to the diffusion of what we're working on, because we get wrapped up in trying to help them, find stable homes, or, the things that we know that are barriers to treating the other problems that are going on. But yeah, the more we can access or find and coordinate that across all the agencies, makes treatment a lot easier, as well as a lot more powerful, I think. And I'm sorry, I didn't have any questions. You did such a good job. So thank you so much for sharing. It was very interesting information, and I'm excited to learn more as you find out more.
Kim, earlier you really identified strongly as a clinician, and I'm curious from your perspective as a clinician, or any of the other clinicians in the room, you're welcome to participate in the chat. Just from your perspective, working with clients, what does get in the way of executing the treatment plan that you had, that you had agreed upon or that you had initiated? What are some of the barriers?
You guys mentioned the crisis of the week. And in MAP, or the Managing and Adapting Practice module or information, they call that COWS, and other people call it COWS, but it just always makes me laugh when I think of crisis of the week and to call it a cow. Those things, the cows definitely get in the way. And with, we're working with kids, and it's hard to say, oh no, we can't deal with that now. We need to, focus on your fear ladder and how we can help you feel better about anxiety when, they're distracted by whatever's happening in the moment. One of the nice things I think with the school-based services is we have a little bit more flexibility of, if there was a crisis, that, we can pull the kid a little later when things maybe have settled, or, deal with that in the moment and schedule our regular session later to help minimize those things. But yeah, definitely it can get hard, and then they get older and teenage, and everything's a crisis of the week. So definitely that contributes to, I think, the diffusion. After supervising VHSs for a number of years, you can definitely see the therapists that spend a lot of time on those cows, I think, get burned out and more dissatisfied with how things are progressing than those that are able to, figure out a way to manage that, in the moment, and get back to what they know they need to work on with the kid to help with the long-term progress. So, and I see from Tristan, there's a question. When were subjects in the study court ordered for therapy? Were the subjects in the study court ordered for therapy? I don't know if any of CAMHD students or cases are court ordered.
Sorry, I was in the process of typing out a
Okay.
response, but I'll just answer out loud. I didn't want to interrupt you or anything when I saw the question. So that data wasn't exactly available. Some CAMHD kiddos are court ordered, but not very frequently from my experience. As like a provider, not as a researcher. So in my personal experience of a provider, I didn't often have kids who were court ordered, and especially not specifically court ordered to CAMHD treatment. So I would say there might be a few, but infrequent, or that had some kind of legal involvement, justice system involvement.
Thanks, Kalyn. And we have a question in the chat also. Just wondering from Fran, wondering if the results might be symptomatic of overall functioning of the youth or family. So number of comorbidities, plus psychosocial stressors, plus parent psychopathology, like which came, chicken or the egg, which came first? That must be the farm theme.
Oh, I like the farm theme, I do. So can't answer all those questions, but in all of our analyses, we did have comorbid diagnoses and initial functional impairment levels controlled for in the models. We obviously dropped them whenever they weren't really contributing much, but yeah, so that was something we accounted for in our model building because we kind of saw that as a proxy for case complexity, which we thought would likely be really strongly related to treatment-focused diffusion. And we wanted to see is treatment-focused diffusion related to outcomes above and beyond just like case complexity or how intense the case is. So I hope that helps. I hope that answered the question.
It sounds like a potential future empirical question too.
Mm-hmm. Yeah, especially with things that we don't necessarily always have the data for with the older MTPS stuff like parent psychopathology or what else did you say on that, Fern? Yeah, the psychosocial stressors, that kind of a thing. I did not have access to the ACEs for this specific data. But also an area I would like to look at. This is really a black hole of research for me, this treatment-focused diffusion thing. I started this in my first year and it might last me my entire career. We'll see.
I'll just say as a clinician, I haven't met many kids who only have one problem. I know when we do training, we do fear ladder and those kind of things. And I can't say I've ever had a kid that just had anxiety. So just, it's how the cookie crumbles a lot of the time.
Elsie, I just saw your question too. So that's an area that I like kind of dabbled in just because for my own curiosity, not anything that I like really looked at hardcore in my models. But some of the things that I noticed that I thought were interesting were that almost every single kid in the database had a treatment target that did not fit into a diagnostic category. So I used some of Allison Love's research where she like looked at the factor analyses, and then I looked at anything that didn't fit in one of her diagnostic categories, and then kind of labeled those as like my other or non-diagnostic things. So I do not remember if positive family functioning was specifically in there, but you know. And that's just off the top of my memory. It's not something that I have in a table. I would like to. I really want to start digging into that to see what are the common threads. Almost everybody also gets treatment engagement at some point, obviously. So it's good to see.
When you were talking about diverting from the treatment plan to address a barrier, I'm assuming that's a good example of diffusion.
I think it depends because if we're addressing barriers in the way that Kim was just talking about with the crises of the week, and every week we're addressing a different barrier instead of trying to get at that underlying, I suspect that that kind of treatment-focused diffusion pattern would be related to poorer outcomes, whereas if it's like there's this one barrier that keeps coming up and is really distracting us from being able to move forward with treatment, or it's like the kid cannot get to therapy because there is no kind of car or anything like that. I think addressing those kind of barriers would be a positive treatment-focused diffusion. Just why I was like, you know, I really want to look into that. Do different kinds of treatment-focused diffusion relate differently?
And I'll just throw in, and this is kind of a maybe not directly related to research, but there is a practice guide that addresses some of the barriers. Accessibility promotion is a particular practice guide that MAP has that walks providers through addressing some of those things. So
There's also a process guide, and I don't know if I'm gonna get the name correct. It might be session planner, but I think really helps to kind of outline what you're going in to do with the client that day, and I think helps to navigate those occasions where crises of the week continue to arise.
yes, having done 2 weeks of MAP training this summer, or sitting through, and being part of one of the trainers for a week of it. Yes, it is the session planner or clinical event structure that does that. It's also a little bit tied into just the regular treatment planner, I think, because it does, part of that is identifying the things that are interfering or potentially could interfere with the treatment focus. So. I see Jeffrey made another comment. He agrees with Scott. Coordinating care and being the point person for a team of caregivers most certainly contributes to diffusion, but it may also improve outcomes because care coordination can be a common treatment target. And there's actually a practice guide for care coordination too. There are 64 practice guides if anybody's interested. And then Karen said, I find that the child's problems are often symptoms of the parents' issues. So the parents are often pulled into therapy with the child as the cause. The child is the canary in the coal mine. We're definitely on an animal theme in this session. I like it. And yes, definitely the identified patient is often the child for the family system.
One of our providers has included a comment just noting the level of collaboration and communication CAMHD has with providers and families that can be seen in treatment team meetings. And I think CAMHD really appreciates also the collaboration from our providers and system partners as well. So thank you, Amanda, for noting that.